right, y'all ready to go?
Yes, sir.
I can see that Conway is ready to go.
Their hand is just frozen.
Good try. All right. So last week, don't put it on me. Please. Last week, the second year semi-answered questions. We're in the third years. Okay. So we got 3 people here and no one at Conway, so y'all can answer all the questions. Last week we talked about colon polyps and premalignant potential and screening and try to prevent colon cancers. And there's a presumably logical route toward forming colon cancers, rectal cancers. And I could spend an hour talking about something I don't understand real well about the different genetic aspects of the colon cancers. So I'll skip over it instead. But 2 of the things up there, the APC gene and the APC gene and P53 are somewhat gateways of shifts in the process of things. The APC occurs early in the process to stimulate the formulation or allow for the formulation of polyps, and P53 seems to be somewhat of a gateway toward converting to a cancer. Unfortunately, as you go along, more and more of these things can be on the quizzes, and you can have to sit down and read about it. One day I may sit down and try to see if I can come up with a logical summary of it, but I haven't found one to copy yet. Nobody gives me a good logical one. And then the genetic instability, microsatellite instability goes in a little bit separate pathway, and that's more often associated with the Lynch syndrome. There's a lot of emphasis on this and reading about it and all, and to date, a genetic predisposition or family disposition for colon cancer is still approximately about 5% or so of the colon cancer. So it's not everybody follows along with the genetic, identified genetic concern. But anyway, we can still have colon cancers for the foreseeable future. And so most of the colon cancer is going to be diagnosed at colonoscopy. Either we can do the colonoscopy or gastroenterologists can do the colonoscopy. Occasionally there are still some primary care doctors that do colonoscopies. So for the third years, when you're doing the colonoscopy or someone calls you who has a colon cancer for colonoscopy, what kind of information do you want from them?
Where the lesion is.
Where the lesion is, that's exactly right. See, y'all are smart. You guessed what I was thinking first. And most of you have heard me say it, and I don't mean it as a joke. I know when I'm in the cecum, and most of the time y'all know when you're in the cecum. Not every time, but that's okay. That comes. And I know when I'm in the rectum. But everything else is the colon. And most of y'all have probably already seen it. The endoscopist will tell you, or you'll think, well, lesions at the hepatic flexure, lesions at the splenic flexure, and the lesion is way somewhere else in the colon, sigmoid colon, just above the cecum, and you don't have a clue. And especially with laparoscopic surgery where you can't feel it, or with early lesions that are small and you can't feel them, you're kind of stuck. And so tattoos with India ink, most all of us have seen those now, are helpful because you can see it from the outside of the bowel, and try to be sure that your referring doctor is tattooing. If they haven't, scope them for yourself and tattoo it yourself. It saves a lot of headache. I I'm old enough for when we used to do a lot of intraoperative colonoscopy to find the lesions that had been referred to us, or even that we had seen. So location and confirming location are important concepts. And again, we mentioned it last week. Still, the majority, probably at least 60% of colon cancers are in the rectum, or colorectal cancers are in the rectum, rectal sigmoid, or sigmoid colon. So the majority of the splenic flexure down. But again, as I said last week, that process is starting to shift, and we're seeing more and more right-sided lesions. It seems that the younger patients have right-sided lesions, and there was a recent article talking about the increased incidence of colon cancer in younger people, aiming down into the 30s and 40s. So for the residents, that's starting to strike home toward age.
Thanks.
And it's true. All right, so we want to know the location of the lesion at colonoscopy. What's the other thing? What's another thing we want to know at colonoscopy?
Size of the lesion.
Size of the lesion, that can really affect a whole bunch of what you do. No, not a bunch. We're talking about cervical colon cancer.
You can fit anywhere but there.
I'm sorry?
You'll see. No, you'll see. You'll see.
We can hear you.
We can hear you.
Makes sense.
We now know y'all are there, Beth.
What?
Your mic is on.
Hot mic.
Morning. So, what's
There's more.
synchronous lesions? Are there more lesions? So how often are you going to find more lesions?
5%.
You got to say it loud. There's an air hammer right here.
5%.
5% for cancer or polyps?
Cancer medicine.
Mostly for cancer. Approximately 6%. 5% is a good number. Mid-single digit. For synchronous cancers, that's important because that really changes what you're going to do. I hope y'all understand what synchronous cancers are. For the students, they're two lesions simultaneously, two separate lesions. About approximately 25% of significant polyps, I tend to keep a number of closer to 40% in mind, but there are significant polyps to be looked for. They either have to be managed endoscopically or incorporated into your surgical plan of how you're going to deal with this patient. On the topic of colonoscopy and synchronous lesions, not for the, I can try that. The students, do y'all know what metachronous lesions are? Any volunteers? All right, someone tell them what a metachronous lesion is. Loudly.
The lesion is actually from droppings of the cells and then implantation of the cells based on the working on.
No, it's not from droppings. Let's have a different answer.
It's a separate primary that occurs at a different time.
The second primary, the same organ or organ system that occurs at a separate time. I have a good example. When I was a resident, I reviewed 8 children under 18 years of age that had colon cancer. And so after I got into practice, I was going down through the clinic, picking up my charts, and I picked up one, and it was a 30-something-year-old guy that on his questionnaire listed that he'd had colon cancer 25 years earlier. And so I went in to speak to him, and I told him all about the colon cancer he had. Dr. Jim Eddy had done his resection, he was like 12 or 13 years old. He'd been put on psychiatry because they thought he was crazy because of his anemia. They finally found his colon cancer and operated on him. Well, 25 years later, I operated on him and took out a second colon cancer, metachronous lesion. Because of the separation, I did a segmental resection, which in retrospect was probably somewhat of an error, because he got where he wasn't so good at coming back for follow-up. And about 5 or 6 years ago, I did his third colon cancer, another metachronous lesion. Now he doesn't have a colon. He does have a rectum, and he does understand to come back for a follow-up now a little bit better. So those would be metachronous lesions that occurred, 3 lesions over about a 45-year span of time. So what's the incidence of metachronous lesions? It's back to the 3rd years. Are you sitting there looking up the answers? Are you looking up the answers? Okay. What did you say?
55%.
35% for cancer. That's not a bad number. Polyps is 20 to 70%. Again, I kind of hold the 40% number in my mind. But for cancer, again, it's in the mid single digits. The combination of synchronous and metachronous lesions is approximately 10%. And so the bottom line is these patients are at a lifetime risk of additional neoplastic lesions, polyps, and cancers. And that's why we do follow-up colonoscopy and do surveillance. It's not a matter of doing the follow-ups looking for necessarily recurrent cancer, because colonoscopy is a low yield tool for finding recurrent cancer. We're more interested in finding additional lesions or new concerns. All right, so you get your colonoscopy, you've done it, you've decided where the lesion is, you don't have any other lesions. Preparing the patient for surgery, what's the next thing you want to do?
Chest x-ray.
You usually don't do a chest x-ray. Tell me what you really do next.
CT.
Okay. Who's French in here? Because I'm not. Anybody know what de rigueur means, or however you pronounce it? Y'all are asleep, or you don't know any French. I looked it up, and because it was written in one of the things y'all were supposed to read for this talk, one of those chapters, I forget which one, and obviously you didn't look it up and you didn't know what it was, or you didn't read it. But anyway, de rigueur means fashionable. They're not studies that say that, hey, we need to do this because this is going to make a big impact on the patient. There are studies to the contrary that say that doing a lot of CAT scans can lead to finding other things that can confuse you, make things more difficult. So there's a mixed bag. So it's fashionable to do CAT scans, but we do, and I'm going to tell you we do. But what are we looking for on the CAT scans? Metastasis. What else? Say it. Well, you might see carcinomatosis. That'd be metastatic disease. What else? Local disease. You know, tumor this big, this can really make it hard to resect, or you can't find it, you don't have a clue. You can help you on location again. Sometimes you see a hepatic collector mass, sigmoid colon mass, you have a little bit of an idea. Obstructive concerns. So location, whether it's resectable, involvement of other organs, you know, those are nice things to know in planning. So I would stick to today, whatever year this is, 2015, and get a CAT scan preoperatively to have an idea. There's also the question of a chest evaluation, which you mentioned earlier. Whether that's a CAT scan or chest x-ray is a little bit debatable. most of the time today, they're getting a CAT scan of their abdomen, so they get a CAT scan of the chest while they're there. And be sure to do the abdomen and pelvis with appropriate contrast to make it a useful test and not be wasting time and coming back later. All right, anything else that you want preoperatively? See, y'all are so good. Y'all copy my PowerPoint? CEA. So why do we get a CEA?
Baseline.
Get a baseline. How does it help you later?
Surveillance.
Is it? In general, if it's not high preoperatively, it might not be of much help. It's more helpful if it's elevated pre-op, you operate on it, you see it nadir go down, and then follow it later. But it is a test to have and to follow. All right. Anything else real pressing to do before surgery? No, it's silent.
Substitute bowel prep.
Didn't even put it on my slides. That's a real questionable thing. Today, we're not doing bowel preps. There is some recent momentum toward returning to doing bowel preps. Both mechanical, and what we're talking about for the students is, do you clean the bowels out like when you do a colonoscopy before surgery? And 20 years ago, we did a full bowel prep just like a colonoscopy, gave antibiotics by mouth and in preparation. And then over the past 10 years or so, the pendulum swung to no prep and no oral antibiotics, just IV antibiotics. There is momentum now for oral antibiotics, and there's developing momentum for mechanical bowel preparation. We're gonna have to watch and see, but I suspect things are getting ready to change. The biggest problem with the oral antibiotics was it was erythromycin base, which is not absorbed. And trying to send a patient out to buy erythromycin base was tough. And it's real tough now. So I'm not quite sure what oral antibiotics will work out to do. Some people are using Flagyl. And neomycin was the other one that we gave, and it was not absorbed either. And that was another one that was, you just didn't run down to CVS and on the spur of the moment get it. But bowel prep, yes, no. Don't forget to have blood available. Some of us get into bleeding when we do surgery. So figure out what's appropriate for your institution, whether it's type and hold or actually go ahead and screening for blood. Just to throw in a caveat, if it looks like it involves things like the bladder or other organs that you could need some help, talk to them ahead of time. I take that one pretty personally. My daddy had prostate cancer, and the plan was the urologist were going to operate on him and do a lymphadenectomy, and the radiation oncologist was going to come do seed implants. He was in his 70s, we weren't going to do radical surgery on him. And so they get there, they do the lymphadenectomy, and they call for the radiation oncologist. This was in Dalton, Georgia, and the oncologist comes out of Chattanooga, and he wasn't aware that the case was on. And you have to have the seeds and all that kind of stuff. That was a personal lesson to me. They ended up putting sleeves in and then loaded him later. It didn't make any difference, but it was a real take-home lesson to me. If you're going to do a coordinated surgery with someone, personally speak to the doctor that you're going to be working with the day before. And there's no excuse otherwise. Call them and talk to them. Not necessarily text them. Talk to them. I know in y'all's generation that those phones actually can carry voice signals. remember that, but it always helps to talk to folks. All right, so you're going to operate on people. And the lesion is down here in the cecum. You can take out the right colon, including the vessels and the right branches, the middle colic, have more little branches coming over. As it moves up to the hepatic flexure, you can extend this over further. And I think it was Miles that ultimately gave us the answer, but we're taking the vessels because we're looking for lymph nodes. And we decided, I think last week we talked about it, today 12 is kind of the gold standard. You want to try to harvest at least 12 regional lymph nodes. And probably better to get 12 lymph nodes from this area as opposed to having a lesion here and finding all the lymph nodes over here. When you start doing these extended right colons, you'll often get 40 lymph nodes and things like that. This operation, Dr. Stratton will do occasionally, and I chide him about it every time he does it. My advice to y'all is to take a transverse colectomy out of your armamentarium. It's a dangerous operation because the colon is fixed here and it's fixed here, and it tends to be an anastomosis under tension, and they have a high complication rate. Dr. Corman in his book puts an X through that operation. So just kind of, unless it just seems like to be the only answer you can use on a quiz, take it out of your armamentarium for surgery. And again, lesions over here, this is not a favorite operation of mine, kind of for the same reasons. This can be a little bit hard to reach down here fixed. It's actually easier to reach this from here to the sigmoid colon. But hepatic flexure lesions, splenic flexure lesions, I tend to recommend doing an extended colon resection. Take out the right side over to that lesion. That ileocolic anastomosis is safer, easier to do, and you've already taken down the splenic flexure, so it's not making it much more difficult. I have a real preference for lesions from about here back if they're obstructing, just to take everything so as to take care of synchronous lesions and all that you haven't been able to see if they have not been able to scope past the lesion. So I kind of like extended resections. All right, I wasn't sure how well this was going to project. On staging, we need to know the staging of lesions. This picture is not just real great to me because, like this line, T1 involves the muscularis mucosa, and the submucosa does not involve the muscularis propria. T2 involves the propria, T3 goes through, and T4 goes into adjacent structures, the visceral peritoneum, or the visceral peritoneum, and goes through. In the TMN classification, you also have a differentiating of 1 through 3 nodes and greater than 4 nodes. And for historical reference, the Dukes and Master Collier are over here. And so, like all the TNM classifications, there's a grid that you work through, and basically the first big separator is the depth of invasion and whether lymph nodes are involved, and you come down. For most purposes, people tend to just do stage 1, 2, 3, and 4, in that invading into the muscle layers of the bowel wall for 2, and through the bowel wall, having lymphadenopathy for 3. But you start getting into 2B If it is through the bowel wall, greater risk. And then 3s are separated into A, Bs, and Cs. Superficially invasive, deeply invasive, more than 4 or more nodes to separate. And the whole reason behind staging is to stratify, to adjust your treatment, and just curves showing that as the stage worsens, the survival worsens. And to me, this line is about the most alarming because that's the stage 1. It's superficially invasive and does not have any lymph nodes, and that just seems like a bad number to me. I tend to think of a little bit better than 90% survival rate, but this particular source is showing 70, 80% survival rate. That's better than that, I think. But the point is, it's a pretty significant failure rate. You know, so if you tell someone that they have a stage 1 tumor, tell them that you're going to follow them just like they had a stage 3 tumor, because they're at risk of getting recurrence. Back again on these 3s, they're separating them out because they do have distinctly different survival curves based upon those findings. All right, and then adjuvant treatment, and I'm not about to profess to tell you all the different chemotherapy drugs and that kind of stuff, but the current the standard is Folfox, which is 5-FU, leucovorin, and oxaliplatin. There have actually been good stepwise studies to show that these work. And it's not just all pure guessing. They are treating stage 2 high-risk patients now, and those would be the 2Bs with invasion through the bowel wall, people with lymphovascular invasion, obstruction, and possibly involvement of adjacent organs. And stage 3, they've shown real improvement in survival. And when you take the survival rate, and that 15 to 20% is a 15 to 20% improvement in survival, that's real, and that makes a difference. And the way I tell it to patients is that if you take 2 groups of about 500 and treat them with surgery and follow them, the ones that don't get chemotherapy versus the ones that do, there'll be successes and failures in both groups. There'll be patients in both groups that will die with their cancer. There'll be survivors in both groups. But down the road, there'll be 15 to 20% people more alive that got the adjuvant treatment. And to me, that seems to help them to understand why they need to go talk with oncologists. All right, our time is up. Do you have any questions?